Right. Hello, everyone. It is now almost 7 p.m. Eastern Time. Thank you all for joining us for the Canadian Liver Foundation and the Canadian Association for the Study of the Liver Ask the Expert webinar on alcohol-related liver disease. My name is Nem Maximovich. I am the Senior Manager of Sport and Education at the Canadian Liver Foundation, and I will be the moderator and host for this webinar. I would like to start by acknowledging the Canadian Liver Foundation's national office in Markham, Ontario, is situated upon traditional territories of the Anishinaabe peoples and of the Haudenosaunee peoples covered by the Upper Canada Treaties. We are joined tonight by our presenters, Dr. Tasha Kulei and Dr. Cynthia Chen from the University Health Network in Toronto, Ontario, and from Dalhousie University in Halifax, Nova Scotia. As for our agenda, we will have the two speakers complete their talks prior to moving on to a question and answer portion. Please feel free to use the comment feed in the Facebook feed to ask your comments, to ask your questions during the presentation, and know that the questions will be answered following the speakers' presentations. This webinar will also be available post-event on the Canadian Liver Foundation's website, which is liver.ca, as well as our Facebook and YouTube pages in the coming days. So if you are unable to attend this webinar live, rest assured that it will be available on our communication channels in the next few days. For those of you who may not be familiar with the Canadian Liver Foundation, or if it's your first time tuning in to a CLF and CASL webinar, I would like to provide you all with a brief overview of who we are as an organization and what we do. The CLF was established in 1969 and was the first organization in the world created to help people with liver disease. We are committed to promoting liver health and improving the prevention, diagnosis, and treatment of liver disease through our four core pillars: research, education, patient support, and advocacy. The Canadian Association for the Study of the Liver, also known as CASL, our partners, they're a nonprofit organization that seeks to eliminate liver disease through research, education, and advocacy. Its members include hepatologists, gastroenterologists, pathologists, pediatricians, radiologists, scientists, surgeons, trainees, and others. At this time, I would like to welcome our first speaker for today's webinar, Dr. Tasha Kulei. Dr. Kulei is a transplant hepatologist at the Dalhousie University in Halifax, Nova Scotia. Originally from the West Coast, she completed her medical school, internal medicine, and gastroenterology training at Dalhousie University, followed by a fellowship in transplant hepatology at the Mayo Clinic. Her research interests include implementation science, frailty, and the topic of today's webinar, alcohol-associated liver disease. I will pass the mic to Dr. Tasha Kulei.
Thank you so much. Let me just share my slides. Is that looking okay there?
Yes.
Great. So thank you so much for having me. I'm happy to be chatting with everyone from Halifax tonight. Just advance here. Hopefully we can get through this part in the first half here now. Going over some introductory slides, just talking about alcohol use, specifically how much is too much, and we'll go over what a standard drink is specifically, and specifically the Canadian low risk drinking guidelines, to discuss those initially to start. We'll also talk about what alcohol does to the liver, like what the normal metabolism of alcohol is, as well as the damage it can cause, what the burden of alcohol-related liver disease is in Canada at this time, as well as just general alcohol use in Canada, and how someone is diagnosed with alcohol-associated liver disease. So first, alcohol use. How much is too much? I'm not sure if everyone here is familiar with Canada's low-risk alcohol drinking guidelines. These were actually released in 2011 and the first ever Canadian drinking guidelines launched by the Canadian Centre on Substance Abuse. So these were meant to support Canadians essentially making informed decisions about alcohol consumption, and they're meant for those aged about 25 to 65 who do choose to drink and how to reduce their risks in the short and long term related to alcohol consumption. And so these were developed on a backdrop of some increasing alcohol use in the kind of decade leading up until their development. And in the past, there was only a different guidance in different provinces. And so just to let everyone know here, today we'll be discussing the current drinking guidelines, but they will actually be revamped, and a new series of guidelines released next year is planned. So in terms of what a standard drink is according to our Canadian low risk drinking guidelines, these differ depending on the country you're in, but in Canada we use 13.6 grams of alcohol. So that might seem pretty vague and unclear in terms of what that actually means. So hopefully this picture is a little bit more clear for you. So really, I think the easiest way of looking at this is in the ounces of alcohol. So when we look at beer or cider or cooler, this is a 12-ounce beer or cider. And when we're looking at wine, that's a 5-ounce glass of wine. For more distilled alcohol, that's 1.5 ounces of alcohol. And so one of these, any of these ones here would be a single standard drink. So it's really important that we have the same language and quantity really of alcohol that we're talking about. So we know when we're talking about the number of drinks, at what point are things risky or dangerous, we're all talking in the same language. So you can see how this starts to get complicated pretty quickly here, because oftentimes people are having a light beer or a stronger beer, or perhaps drink their alcohol more in bottle form than in glass form. And often things like in restaurants, glasses of wine are much larger than 5 ounces, and perhaps at home for you too. So the guidelines for consumption limits in Canada's low risk drinking guidelines are different for women and men, and we'll talk about why that is a little bit later. But for women, the guidance is to have no more than 2 standard drinks per day. So for example, 2 5-ounce glasses of wine per day, but a total of only 10 standard drinks per week. So not having that 2 maximum every single day, or you'd be exceeding that. Special occasions, having about 3 standard drinks perhaps, maximum, and avoiding alcohol on some days as well. For men, that increases a little bit to 3 standard drinks per day, a total of 15 per week, and 4 on special occasions. And again, to not try and drink every single day. When we talk about what binge drinking would be, it would be in excess of these amounts for special occasions. So kind of 4 or more for women, or 5 or more for men would be considered binge drinking in general. This is just another way of showing the same information for you. So the recommendation for women would be 0 to 2 drinks per day, or a total of 10 per week. And for men, 0 to 3 per day, or 15 per week. So what if someone is drinking in excess of this amount? So if someone is drinking in numbers beyond our low risk drinking guidelines, does that mean that someone is an alcoholic in terms of colloquial terms people sometimes use? And that, of course, the answer would be no. So what we'd be referring to instead in terms of using alcohol at higher amounts beyond the low risk drinking guidance is more risky drinking. So meaning it's associated with short and long-term risks related to your health. So really drinking starts to be quite risky from injuries or accidents, in terms of violence, alcohol poisoning, when men and women drink more than a few drinks within a couple of hours. And of course, in long term, when you're starting to exceed that 10 drinks a week for women or 15 for men, that's when we're talking about the long-term risks. And so you can see some of them you might be very familiar with. So especially, of course, like car accidents or other violence or accidents short-term, and long-term especially, we'll be talking about liver disease today. So this is a little bit separate and often unrelated to having alcohol use disorder, which people may think of more commonly when we're thinking about things like alcohol dependence or addiction. So in the past, we had a few different diagnoses to kind of classify someone as having an addiction issue with alcohol. Currently, this is the criteria for having alcohol use disorder, and this is from what we use in medicine as the DSM. It's published, a manual essentially published by the American Psychiatric Association. And what it does is gives us a guidance of how to diagnose severe psychological or neurological conditions. And so you can see that you just have to have a couple of these symptoms on this list of 11 to be mild. If you have 4 to 5, you'd be moderate, or 6 or more severe. And so some of these might include things like having cravings or having alcohol affect your ability to fulfill your usual obligations at work or at home, or things like you might be thinking of more typically like having tolerance or withdrawal related to alcohol. So what does alcohol then do to the liver itself? We'll talk about alcohol metabolism here for a little while. So I don't mean to alarm you with all of these little metabolism pictures here. So when you consume alcohol, some of the alcohol you ingest goes into your stomach and doesn't enter your systemic circulation. It is oxidized or kind of degraded somewhat in the stomach by this enzyme that we have in the liver. We do have a little bit in the stomach. And so alcohol, if you have an empty stomach, is kind of passed through that system of degradation much more quickly. And so more would be seen by your liver than if you have a lot of food in your stomach, allowing the alcohol to stay there and get oxidized a little bit more extensively. So in a fasting or empty stomach, more alcohol is then kind of going into your small bowel here and then being absorbed up into your liver. And the major enzyme systems that are responsible for oxidizing or breaking down alcohol, or what we term ethanol, are really all in the liver. So the liver sees the biggest extent of alcohol metabolism in the body. And so essentially the main enzyme system in the liver that breaks down alcohol is this ADH, their alcohol dehydrogenase. And so as I mentioned, majorly in the liver there. And what it does is it needs a vitamin cofactor called NAD. So it's a component of niacin, and it uses that to break down part of the alcohol. And it breaks down alcohol to acetaldehyde, which you may have heard of before, perhaps not. So the acetaldehyde is then broken down further by another enzyme called acetaldehyde dehydrogenase, which breaks it down to acetate, which this actually then leaves the liver itself and can go throughout the blood system into the other tissues, where it's converted into more of a compound that other foods you would generally eat tend to get converted to. And so ultimately that's broken down into fat. So when we look at the actual damage that can be caused by alcohol, the acetaldehyde here is quite a reactive and toxic compound that can be responsible for what you might be familiar with as the systemic like toxic effects of alcohol, like having nausea, headaches, flushing. And it's thought that this might cause some damage to the liver specifically as well. So there's a few different mechanisms that it can damage the liver. One of the things is that also too, just from exposing the body to so much ethanol, you really lose your little NADs here that are transformed into NADH, which might sound kind of meaningless to you, but within the liver itself, it means that they aren't available to then degrade or metabolize other products like carbohydrates or fat. And you have less energy molecules in the liver to do other things, those energy molecules being called ATP. You also end up with increasing liver fat. And so you also have increased liver damage related to alcohol through other routes. So like having lower oxygen in some parts of the liver, having also some immune and inflammatory mechanisms. So this is primarily often driven by the lining of the intestines becoming different when you're using alcohol regularly. The lining becoming more permeable, there being different bacteria there, which can also affect how the liver is functioning. And there's also a lot of other sex and genetic factors as well. So women generally weigh less than men, and because of that, they tend to reach higher blood alcohol levels than larger individuals, which are generally men. Even if a woman does weigh the exact same as a man, there is less water in her body. So if they both were to drink the exact same amount of alcohol, she would see a higher blood alcohol concentration. There also is potentially less of these alcohol dehydrogenase enzymes in her stomach too, which might lead to more kind of direct alcohol exposure in the liver. So some of those are reasons why the recommendations for women are lower than for men. So what does the actual alcohol do to the liver itself? So this is what the liver looks like under a microscope if we take a piece of the liver and look at it. And so this is kind of normal tissue here. And one of the more expected and predictable responses that we see when people drink alcohol regularly. So for example, if you were to have a holiday or some time period where you decided to have 4 drinks a day for a couple of weeks, almost 90% of people would end up with fat in their liver. And that's these little kind of white globules. I don't know if you can see those very well, but that's the fat kind of developing in the liver. And this is a reversible condition, as are some of these other things here too. But really, if you were to stop drinking at that point, after about a month or so, your liver would look normal again. And so whether you have progression beyond fatty liver into these various stages, ultimately ending up with cirrhosis, is dependent on whether you have continued heavy alcohol use and whether you have other risk factors as well, including, we talked about having the female sex, some genetic components, diet, and whether you might have any other like comorbid liver disease, for example. So really, once you get to having fatty liver, certain subsets of the population end up with quite severe inflammation related to alcohol in the liver called alcohol-associated hepatitis, or some scar tissue. Fibrosis is in the liver is what we term some degree of scarring, which is just a reflection of chronic damage. And a lot of scar tissue is what we call cirrhosis. Initially, the scarring is quite thin and lace-like, and it gets thicker and more macronodular with time. And once you've developed cirrhosis, there is a risk of then developing complications of cirrhosis, which I imagine Cynthia would talk about a bit more, but those would include having liver cancer or hepatocellular carcinoma. And this is ascites or fluid in the abdomen. This is looking down the food pipe and down in your esophagus, and this is what looks like almost a varicose vein, so that can pop and bleed, what we term variceal bleeding, as well as confusion from liver disease, which is called hepatic encephalopathy. So how much alcohol-associated liver disease is there in Canada? It's a bit of a difficult answer or question to answer. We can talk about alcohol use in Canada, I think, a little bit more clearly, but we don't really have a lot of great statistics on alcohol-associated liver disease. So for alcohol use in Canada, we do know some data, especially from 2015, that about 77%, or most Canadians really within that year that it was studied, did drink at least 1 drink of alcohol. It's a little bit more common in men than women, as you can see. But really quite a high number of people do consume some alcohol. When we think about some of the health-related risks, we'll talk more about liver here today, but there are a lot of other issues, especially chronically, that individuals can get with regular alcohol use, especially in excess. And there was, in that 1-year period, about 56,000 different Canadians hospitalized just for alcohol-related complications. And some of those had more than 1 hospitalization. So in total, there was about 77,000 hospitalizations. And to put this into perspective, that same year, there would have been about 75,000 hospitalizations for a heart attack. So a higher number than that every year related to alcohol. Not all of these would be liver disease. When we look at those low-risk drinking guidelines we were talking about, so the 2 per day drinks for women, 3 for men, who's exceeding that, like in terms of percentages? And this is, again, similar time period. Overall, about 20% of individuals exceed those drinking guidelines. So potentially at risk for the short and long-term complications we talked about. And so in terms of alcohol-associated liver disease, this is a bit trickier to tease out. We looked at the different kind of spectrum of disease. There's not a lot of research or evidence available to say what % of individuals in the Canadian population have each stage of liver disease. This study was just looking at individuals with cirrhosis specifically, and this is data from Ontario from 2000 to 2017, just in this part of the graph here. And so you can see the alcohol-related liver disease part is in green, and so it stayed quite stable over the study period. And they also did some projections to see what we'd expect to see over the next couple of decades ahead. You can see it's expected to go up just a little bit, but be relatively stable. Fatty liver, on the other hand, from non-alcoholic fatty liver disease, which we're not talking about tonight, certainly increasing, and overall the number of individuals with cirrhosis increasing as well. Within this, though, although it looks stable, when we look at the actual groups of individuals who are having alcohol-related liver disease, I'm sorry, there's a siren going on here. So the younger birth cohort here from born after 1980, so younger individuals, they are projected to have a significant increase over the next couple of decades ahead here. Or you can see the baby boomer cohort over time is expected to have less alcohol-associated liver disease. Some of that is just going to be mortality for these individuals as well for other reasons. And so this is quite an alarming rapid increase in cirrhosis from alcohol-associated liver disease in this study, and it's been seen in other studies in other countries as well. And it seems to be coinciding with an increase in binge drinking in younger individuals over the last many years, especially in university students once they leave home. And so unfortunately, projecting to be quite a common situation for younger people as time goes on. We also do know some information about the transplant waitlist in Canada. This is probably our last information we'd have before COVID-19, so a little bit more reflective of our usual situation. You can see in that year, they had 610 liver transplants completed, with a number of individuals still passing away, unfortunately, on the waiting list, as well as many people remaining on the wait list. But this isn't specifically just for alcohol-related liver disease. Most of these people, in fact, have liver cancer that they're being transplanted for, probably about 23% or so. So specifically for alcohol, if we look at people who did go ahead and get a transplant, and this is over a course of a 10-year time period here in Canada, you can see alcohol is a pretty common cause or reason to get a transplant in Canada. So especially for our individuals aged 35 to 59 or over 60, you can see alcohol is very high up on the list, really, but just behind cancer in terms of the reason that individuals need to get a liver transplant. So the last part we'll go over is how is someone diagnosed with alcohol-associated liver disease. So when we see someone with liver disease in our clinic, we go over a few main things. So first of all, we take a history or talk to the individual we're seeing, perform a physical exam, and do some investigations as well. So when we talk about history, really a lot of the things we're looking for are not necessarily specific for alcohol use or alcohol-associated liver disease. Really, to get alcohol use history, we just have to talk to each individual, and often it's quite a detailed history we have to try and get throughout their lifetime about their alcohol use. And going back to the standard drinks we talked about is often very helpful, so that we're all speaking the same language. Symptoms, they're often maybe none at all. Often liver disease is kind of like what people consider high blood pressure, where there's no symptoms until things can be quite severe. So depending on the degree of liver injury and the degree of liver damage over time, whether an individual has cirrhosis or complications of cirrhosis, really depends on what symptoms they may have. And some symptoms also may be related to alcohol affecting other parts of the body too. So again, commonly, especially early on, there may be no symptoms, but having low energy or low appetite, sometimes abdominal pain, which can be a bit vague, yellowing of the eyes or skin, or jaundice can be present. Again, these aren't necessarily specific to liver disease from alcohol. Sometimes alcohol can damage the nerve endings in the legs or the hands, so that can cause a type of neuropathy, which people feel as a numbness or shooting pains. And with complications of cirrhosis, sometimes people can get confusion or sleepiness during the day, but more awake at nighttime. They can gain fluid, but also lose muscle mass, potentially lose their sex drive or menstrual cycles. And when we look at an individual, again, with liver disease, oftentimes if things are early on, we might not see any changes at all. One of the things we're commonly looking for, which can be a sign of cirrhosis or more advanced liver disease, is what we call spider angiomas. These are little kind of red spots we often see on the chest in people. It's normal for women to sometimes have a couple of these, but to have more of those along the chest or back, sometimes they're on the upper limbs or hands. As well, we can sometimes see some redness or palmar erythema on the hand. And another hand feature we can see is Duplitrin Contracture, which sometimes we see more commonly related to alcohol-associated liver disease. So this is where you can't really extend this finger. You can see the thickening of the tendon there. The nails often look white here at the base instead of the normal color that's along the rim. That's what we term Terry's nails. Sometimes easier bruising. Men can also get enlarged breast tissue, or what we call gynecomastia, related to liver disease. And the jaundice or yellowing of the eyes and skin we talked about. In more advanced liver disease, you could develop a loss of a lot of muscle mass in the arms and legs and retaining fluid in the abdomen that we call ascites. And sometimes we get people to stretch out their hands and kind of bring their wrists back. And if they're not able to keep them up there and the hands keep kind of falling back, that's a sign potentially of increased toxins in the body, or what we call asterixis. Other investigations we sometimes do would include blood tests or different scans, and probably less commonly a liver biopsy. And blood work that we would look for would be really any abnormal liver tests over time. We try to look back at any other blood work an individual would have had in the past. And there's a specific pattern to their liver tests that's typical for alcohol. We also often see larger red blood cells related to alcohol, and sometimes a low number of red blood cells, which is what's called anemia, or low platelets. And when we do imaging, whether it's an ultrasound, CAT scan, or MRI, sometimes the liver looks fatty. Or if you have cirrhosis, which would be down here, it can look bumpy on a scan. And sometimes also seeing some other features related to the liver too, that are signs of high pressures around the liver, or what we term portal hypertension. So that might include a larger spleen that would then also suggest cirrhosis. When we look at the liver under a microscope, we're looking back at those changes we saw on the other slide. So some degree of scar tissue, which would be a marker of chronic changes in the liver, and some specific features of alcohol damage. So overall, we just had wanted to go over in the first part here that hopefully you can see that alcohol is a significant health problem in Canada. And regular alcohol use, especially in excess of Canadian low-risk drinking guidelines, can cause significant liver damage. So it's important to be wary of what the size of a standard drink is when you're thinking about regular alcohol use and how much you might be getting in an average week. And to be cautious too, often there's no signs or symptoms you may see until liver disease is quite severe. Thanks for your attention.
Perfect. Thank you for that, Dr. Kalai. Very, very informative introduction on alcohol-associated and alcohol-related liver disease. I think it gives everybody a good idea as to what it is or what the condition is, and of course, the diagnosis process as well. At this time, we'd going to welcome our second speaker, or second presenter. We have Dr. Cynthia Chen. Dr. Chen completed her residency in internal medicine and gastroenterology at McGill University in Montreal. She underwent extensive training in hepatology during her fellowships at the Toronto Center for Liver Disease and at the Cleveland Clinic. After her fellowships, she worked as a clinical associate at the University Health Network in Toronto until she was recruited as an assistant professor of medicine at the University of Ottawa. Cynthia obtained her Master of Public Health at Johns Hopkins University and developed significant interest in teaching and postgraduate education. I will pass it on to Dr. Cynthia Chen.
Thanks so much. And just as an aside, that's a really small amount of alcohol for the safe drinking guidelines, eh? For women, 1 or 2 drinks a day. I know when I tell my patients, they're always like, really? You know, society has kind of normalized alcohol, right? So just, you know, people think it's normal. Yeah, 1 or 2 drinks a day, not a problem. And, you know, our alcohol guidelines are saying that might be a problem in some people. So it's very interesting. So I was asked today, I was asked today to talk about more the management of alcohol-related liver disease. And these are my financial disclosures. And so I wanted to talk about the treatment of the underlying etiology of the liver disease. So basically like alcohol use, treatment of symptoms and complications associated with alcohol-related liver disease, and then some slides about the prognosis and liver transplantation. And the reason I divided it in this way is that, you know, alcohol is just another cause of liver disease. And actually, a lot of the causes of liver disease all kind of do similar things. So I have this slide on the natural history of liver disease, and this is for hepatitis C infection. And then I'll show you one for alcohol, and it's very, very similar. So whether you have a virus or alcohol or a genetic condition or an autoimmune condition, it all kind of affects the liver in the same way. So you have something that causes damage to your liver and inflammation. So that's here, like this chronic hepatitis. So inflammation of your liver. And then over many, many years, that inflammation and you know, the liver repairs itself and then it gets damaged again and then it repairs itself. All that scarring over time leads to cirrhosis. And then you can have cirrhosis for many years without actually knowing that you have it and have no symptoms at all. And then you can develop those complications that Tasha was talking about, like the cancer and all these complications of end-stage liver disease and then death. And so alcohol is really similar to like all these other diseases. The one exception is that you can also get this alcoholic steatohepatitis that she was talking about. So again, with alcohol, it's very similar. So you have your normal liver and fat and inflammation and scarring and cirrhosis. And then on top of that, at any point in time, you can have this very severe inflammation. And so when I think about alcohol-related liver disease, I think about it similar to my other diseases in that, can we treat the underlying problem? So if you had a virus, I would give you an antiviral medication. If you had an autoimmune condition, I would give you something that suppresses your immune system. With alcohol, I think about how do I treat the underlying problem? And then, you know, all these liver diseases cause the same issues, the decompensation, the cancer. And so then that's why my second part is really about talking about treatment of these specific complications. So just a little bit of note, alcoholic hepatitis, because it is unique to the other liver diseases. It's caused by excessive alcohol intake. And what makes it unique is that it can develop very suddenly and it can be very, very fast. So it can very quickly lead to liver failure and death. And that's because there's really excessive inflammation of the liver. And all that inflammation leads to a lot of cell damage and cell death. And it can be very non-specific. So you can just develop this abdominal pain, nausea, you don't want to eat anything, you just feel unwell, and then you can get very, very yellow and fatigued and even have some fever. And this is unique from the other liver diseases, as I said, it can very quickly lead to death. So when we talk about treatments for alcohol-related liver disease, like if I had a virus, I would give you a pill to treat the virus. So for alcohol, unfortunately, abstinence, or basically stopping alcohol completely, is the only proven therapy for alcohol-related liver disease. So people have tried different things, anti-inflammatories, things to prevent all that cell death. It hasn't really been shown to work. And really the only thing that's been shown to improve things is stopping alcohol completely. But there is probably a point of no return. So, your liver has an amazing capacity to regenerate, but at a certain point, the liver is probably so scarred and damaged that it doesn't come back. And so we see with these slides, and it looks really confusing, but essentially, they separated people into sort of early and late stage cirrhosis, okay? So at the end stage, when you have all that scarring and damage of cirrhosis, we divide it into sort of like mild, moderate, and severe. And so what they saw was that in people with mild to moderate disease, okay, versus people with severe disease, you want to be as close to 1 as possible, okay? Because this is the survival. So if it's a 1, that means you're alive. So you want your line to be close to 1. And what they saw was that if you had alcohol-related liver disease and you stopped drinking, you had a better survival than if you kept on drinking. So that's clearly there was a clear difference in that the people who stopped drinking, they had a better survival because their curve was closer to that 1 than people who kept on drinking. But that was only for like relatively earlier stages of disease. And so there probably is a point of no return with very severe liver disease that if you don't stop drinking, like even if you stop drinking, your liver will not be able to regenerate enough to, help you out. And then we need to think about liver transplantation. And it's really hard to tell like who is who, right? Like, so some people stop drinking and then we see a really good effect, and some people we don't. And so it's very hard to tell where is that line? And so that's why I usually tell patients, you don't want to go up right to that line, right? Because you may have crossed that line already. Like there's really no way of knowing. So you don't want to, it's like falling off a cliff, right? You don't want to go straight to the edge and kind of flirt with that edge and see how close you get to the edge. You really want to, be well away from the edge so that, you don't want to fall over that edge and not be able to come back. So Tasha kind of talked about this, how some people drink alcohol and can stop, and some people have it is a disease, it's a disease just like hepatitis C, just like autoimmune liver disease, liver disease, it's a disease. So there's actual diagnostic criteria to diagnose people with alcohol use disorder, which is the disease. And so this is a very busy slide, but I'm just going to focus on 3 things. So there's a social impairment, there's risky use, and there's physiologic dependence. So that's what Tasha was talking about. You're using alcohol in a situation where you are in danger, right? Because that doesn't make sense, right? If you are saying oh, you're going to fall over a cliff if you keep drinking, and then you keep drinking, that's risky use, right? You're doing something that is at risk to you. And then there's social impairment where alcohol is preventing you from, playing a role in your society, right? So your family, your work obligations, it's impacting that in a negative way. And then there's the actual dependence. So, when you think about people who are addicted to other substances like narcotics and things like that, right? So, in the movies, people stop taking that substance, and then you can see there's withdrawals and things like that. So those 3 things would actually diagnose people with an alcohol use disorder. And, it can be very difficult to realize because, as I said, it's so common in society. Alcohol is the most common drug, right? That is actually sanctioned by our society, and we make money off of it, right? So it can be really hard to recognize when there's a problem or not. And so we actually like advocate for doctors to try to screen people for alcohol use disorder. And so we try to keep things simple, right? Like try to keep it as simple as possible. And so really the screening question is, how many times in the past year have you had 4 or more drinks in a day for women or 5 or more drinks in a day for men? So that's just the screening questionnaire. And then if you say yes to these questions, like if any one time in the past year you've had more than 4 or 5 drinks, then you should probably see your doctor about performing like a formal questionnaire. So there's something called an audit questionnaire that the doctor can do. And there's 10 questions on the things that we were talking about, like how much you drink, are you having symptoms of dependence, and is the alcohol causing problems in your life? And depending on the score, you may be diagnosed with a moderate or severe alcohol use disorder. And like, obviously the screening is very broad, right? Like college students are probably all gonna go, score positive on that. But it's important to kind of have that self-reflection and to, speak to your doctor and get screened on that to see, if there is a problem, because as you can see from Tasha, like it's very, very common. It's extremely common. And you really want to catch this early. From a liver perspective, I want all of you to have healthy liver. So it's good to catch this early and potentially not run into problems down the road. So if you actually are diagnosed with an alcohol use disorder, usually you need to have 2 approaches. So medication, so just like I said, Hep C, autoimmune disorders, you give people medications. Alcohol use disorder is a bit unique in that you also should have psychosocial or behavioral treatments. And that's been shown that if you have 2 treatments together, you get better rates of alcohol abstinence. So people stop drinking at higher rates if they get, treatment with medication and with this like behavioral therapy, basically, like psychosocial treatment, we call it basically. So because a person is not just like, it's very Western, right? Where we just give people medications, right? But if you there's a trend now to be more holistic and to look at a person as a person and say, hey, what's the mental causes of, excessive alcohol use, right? What are the social determinants of health? Like, what is the social situation that's causing people to turn to alcohol, right? So there's a big push to try to have these integrated clinics where you might have a psychiatrist along with a social worker, along with a medical provider, so that you can get, these psychosocial therapies, so like cognitive behavioral therapy, motivational enhancement therapy with medication and medical care. And it does increase rates of alcohol abstinence. Now, the issue is it can be very difficult to access these things. I am in the healthcare system, and I find it very confusing to link people up to resources because, again, we are good at giving people medication, but we're not as good at giving people sort of that holistic treatment. And so there's been a lot of different approaches to trying to help people stop drinking to excess. And there's everything from inpatient alcohol rehabilitation. So that's often used for people who have very severe withdrawal symptoms and so need inpatient treatment so they can have medication to get them through the withdrawal. There's also group or individual therapy, which is slightly different from these mutual aid societies like Alcoholics Anonymous. There's also therapy, like cognitive behavior, motivational interviewing, where you just try to motivate people to try to stop drinking. And there's actually this is the kind of stuff that it's kind of difficult to do, sort of like a randomized controlled trial. So there isn't a lot of data to show that, CBT is better than motivational interviewing, is better than AA. So what I tell people is it's just really what kind of fits your personality. Some people don't really like AA. They don't like the religious aspects of it. And that's totally fine. So if motivational interviewing fits you better, you can do that. If group therapy fits you better, go ahead and do that. There's really no data saying one is better than the other. It's really very individual. And so what I have taken to do, because, you know, there's a lot of resources in the community, but it's accessing that resources. And so you know, in Toronto, we actually have people from all over the place, like at our transplant center. We're seeing people in Kingston. I worked in Ottawa for a bit. You know, we're seeing people from like Timmins and Sudbury. And so all the resources, it's very local. Like there's usually a lot of local resources that we may not know about. So I usually refer people to this provincial website, and it's a free number. And then you can call and you can kind of say where you are, what you're looking for. And they try to link you up with what is basically what your needs are. In terms of medications, you know, I'm going to list these medications. We are actually, you know, there's not a lot of data in the alcohol related liver disease area. So these medications have been used for alcohol use disorder, but, you know, for people with also coexisting liver disease, there's actually not a lot of data. So there's certain medications that are FDA approved and not FDA approved. The ones that are FDA approved are naltrexone, acamprosate, and disulfiram, but we don't recommend disulfiram because it's potentially toxic in patients with very severe liver disease. And the naltrexone and the acamprosate actually have not been studied in alcohol-related liver disease. Not to say that you can't use it. You know, actually a lot of people do use acamprosate in patients with liver disease because it's excreted through your kidneys rather than your liver. So it's probably like the safest of these drugs to give to people with liver disease. But there is a lack of studies. And this is sort of an area that, you know, definitely we should advocate for more research into this area because it's very important, and we would really like to help people and really increase their chances of you know, reducing their alcohol consumption and stopping it completely when necessary through medications. So naltrexone can be given in patients with liver disease, but there are some hepatotoxicity concerns. So it may be more useful in people with sort of early stage liver disease. And then there's non-FDA approved medications like gabapentin, baclofen, and topiramate, but people still use these as well. So particularly baclofen, there was a study that showed that it did reduce alcohol consumption amongst patients with very severe liver disease. So I have a lot of colleagues who use quite a bit of baclofen. So these are sort of used off-label, but under supervision of your physician should be safe. And we're really trying to increase, you know, education among physicians to be more comfortable prescribing these medications. So I'm going to talk now about treatment of symptoms and complications associated with alcohol-related liver disease. So going back to, you know, our initial slide, we're now going to talk about the sequelae. So, you know, if unfortunately, you know, you're someone who didn't realize that they had cirrhosis and now is diagnosed with cirrhosis, like what can one expect? So some people go many years without developing any symptoms, but then some people do develop these complications. And so, oh, and sorry, I divided it into sort of, you know, treatment of like these complications and then treatment of alcoholic steatohepatitis, which unfortunately is also, there's really like a lack of good evidence-based treatments for this. So some people do give steroids for alcoholic steatohepatitis, but they haven't been really shown to be effective long-term. May be helpful for the first 30 days after diagnosis, but really it's not really a great, it's not like the Hep C drugs that, you know, now everybody's being cured. Like we really don't have treatments for alcoholic steatohepatitis, except for, as I mentioned, stopping drinking completely and hoping that your liver has enough reserve to kind of heal on its own. If we talk about these complications, so I actually recently did a talk on the complications of cirrhosis, and that one was like 40 minutes on its own. So this is a really abbreviated, you know, like very quick summary about treatment. And I think the most important thing is that, you need a referral to a specialist. Like once you have these complications, you really do need to see a specialist to assess and identify and treat these complications, because I'm just sort of scratching the surface here. There's actually a lot, like I said, this section could be a whole talk in itself. So Tasha mentioned ascites. So basically that is fluid in the abdomen that is occurring because of the effect of the liver on the kidneys. So because it impacts the kidneys thinks that it needs to retain water and salt. And so you tend to retain that water and salt in your tummy or in your legs. And then there's something called esophageal varices. So what happens with the cirrhosis is that basically there's blockage of blood flow through the liver, because your liver has now become all hard and it's very difficult for the blood to flow through it. So, you know, the blood starts flowing in other areas because think of it like a dam, right? Like the dam has stopped the blood from flowing, so it's going to start going in other areas. And so what you get are these dilated veins, similar to kind of like varicose veins in your leg. So very large veins, but they're inside your esophagus. So this is your esophagus. That's the tube that goes from your mouth to your stomach. And if you have a camera that goes down, a gastroscopy, you would see these big, large, bulgy blue things, or the veins that you can see going down into your stomach. And those are the varices, and they can bleed. And then lastly, we talked about encephalopathy, which is basically, you know, your liver can no longer process toxins and remove them from your body. And those toxins affect your brain and make you confused. So that's called hepatic encephalopathy. So there's many treatments for ascites. Usually the first thing we always do is we tell people to restrict the amount of salt that they're eating. And that's because water tends to follow salt. So the more salt you eat, you know, think about, you know, when you had a nice meal at a Chinese restaurant and then the next day you woke up all puffy and your ankles were puffy. So sort of similar to that. So we tell people to avoid salt. We can put them on medications that make them pee out the excess water. And then we can also remove the fluid physically. So I'm sorry if people are squeamish, but so this is basically a picture of the water in the tummy. And then you can take a very small needle and put the needle in the abdomen and actually manually remove the fluid. Now, these are all sort of just temporizing measures. Like at the end of the day, all of this is happening because the liver is not functioning. And so that's why I'm going to talk about liver transplant. But this is sort of a way to temporize and make people feel better until you can sort of take care of the definitive problem, which is the liver being all scarred and not functioning anymore. And then for the varices, we basically will treat them either with medication or with something called a gastroscope. And I'm sorry if people are squeamish. I forgot to warn people about some medical images, but basically a gastroscope is a thin, flexible camera. So the camera is at the end and the light source is at the end, and it's a flexible tube, very small, like about the thickness of your pinky finger. And you can see here that the doctor will usually sedate you, give you medication to make you nice and relaxed, put the camera into the mouth, go down directly into the stomach. And then this is the view basically going in. And then you can see some varices. And this is what happens. They can bleed. So usually people don't have any symptoms until they start bleeding. So that's why it's important to have screening. So the idea is we catch them before they pop and they bleed. You can see that's a lot of blood. So you can get very, very sick from this. And what we do is we have rubber bands, and then we put the rubber band on the varix and it squeezes them and it compresses it so it stops the bleeding. And then the band falls off and then you poop out the rubber band. So it doesn't stay there forever. It usually comes out like in a week or so. And then again, so you might need to have this procedure a couple of times to get rid of all the varices. And again, you know, the idea is you want to try to fix the underlying liver so you don't get these complications. And then finally, I was just going to talk about the encephalopathy. And essentially what happens, as I said, is that your body is creating all these toxins. So basically what happens is when you eat food, protein gets broken down into ammonia, and this ammonia goes out into your blood, and usually it's supposed to be processed by your liver, but if your liver is sick, it can't do it anymore. And so these toxins just float around and they go to your brain, and then they can cause confusion and even coma. So it starts off as maybe, you know, you're a bit irritable, you have what we call day-night reversal, so you're up all night and you sleep during the day. And then as it progressively gets worse, you may not know where you are, you may not know who you are, and then you could go into a coma. So the idea is, you know, how do we get rid of those toxins? You may be given a medication called Lactulose, which is terrible, sickly sweet, but it's very effective. And what it does is as you swallow it, it goes through your colon. And, you know, this is where this is where there are bacteria that are producing all these like toxins. And so it changes the bacteria, and you have less of those toxins being generated. So finally, just to finish off, I just want to talk about, you know, what happens if you have alcoholic hepatitis? What if you have cirrhosis and these complications? Like what is the expectation? What is going to happen? So if you look at just cirrhosis and developing these complications, so we divide it into things called compensated cirrhosis and decompensated cirrhosis, okay? And you can see here, this talks about the 1 year and 5 year survival. So what that means is if you take 100 people and you follow them for 1 year, 99% of people will still be alive at that 1 year. And so when you have compensated cirrhosis, which means you don't have any symptoms at all, you have a very good survival. Like you know, you need to have some monitoring and things like that, but you don't need a liver transplant or anything like that. About 5 to 10% of people per year become decompensated. And that means like they have the ascites, they have bleeding varices, they have encephalopathy. And once that happens, then you can see their survival really goes down. So if you have what we call refractory ascites, so you need to get a drain done every 2 weeks, and you follow those people for a year, only 50% of people will still be alive at 1 year. And so really this is kind of the dividing line into when you start needing to see potentially like a transplant service, because now the outcomes are much worse if you keep your native liver. Now, the good news is, as I mentioned, your liver can recover after you stop drinking alcohol. So even though once you become decompensated, you don't always have to stay decompensated. So there is some hope. So that's the great thing about alcohol-related liver disease. It's just like Hep C. If you treat it, i.e. you stop drinking completely, there is a possibility that you can go back from decompensated to compensated cirrhosis. But as I said, you can't wait too long because there is definitely a point of no return. If you look at alcoholic steatohepatitis, this is a very confusing slide. I just want you to look at one thing, okay? So basically, this is the 6-month mortality. And what that means is, if you've been diagnosed with alcoholic hepatitis, there is a huge spectrum in the probability of death, okay? So what this means is, if you followed people for 6 months, how likely is it that they would die from the alcoholic hepatitis? And you can see there's a huge range. It ranges from 10% to 90%. And so we do have some ways of figuring that out. So we use things called the MELD score. We use things called the Lille model. Essentially what these are just blood work. Like we take blood tests, we put it in a calculator, we come up with the number. And basically, like the worse your scores are, the higher the probability of death. So I think what's important to come away from this is that there's a huge variation with alcoholic hepatitis. You know, some people will be fine. Some people have a very high risk of death. And that because certain high-risk individuals are unlikely to survive, we've been talking about transplantation. So it used to be, and you may have heard about this, there was a 6-month rule. So if you looked at the consensus conference, so basically this is the American Society for Liver Disease. So these are all the liver hepatologists and the Transplant Society in 1997, which, oh my gosh, it's over 20 years now. Their consensus was that we needed a 6-month rule. So people had to stop drinking, be observed for 6 months. And their argument was that, you know, we want to see if the liver recovers, because maybe you don't need a liver transplant. Maybe, you know, things will get better. Things have really changed now. So in 2019, the new guidelines said that candidate selection for liver transplantation should not be solely based on a fixed interval of abstinence. So it shouldn't be, you know, 5 months and 20 days, you can't have a liver transplant, and then 6 months and 1 day, now you can have a liver transplant. Instead, they said that it should be considered in carefully selected patients with favorable psychosocial profiles in severe alcoholic hepatitis not responding to medical therapy. So now we think that, you know, there is a certain section of patients we know are not going to do well, probably are not going to survive the 6 months. And if those are people that we think are not going to drink again after a liver transplant, why don't we just do the transplant instead of waiting 6 months? And I think the idea is that really it's about being selective. So, you know, this is a very busy slide, but basically I just wanted to show you that, you know, liver transplant does have excellent outcomes. So you have people, you know, who, like, again, this is survival. So you want to be as close to the 1 as possible. And what it showed was that, you know, if you had really bad liver disease and you didn't get a transplant, you can see you are the line farthest from the 1. People did not do well. If you responded to treatment, there is a segment of people who do respond to, say, like steroids. They did quite well. And if you had a transplant, then you did similar to those people who responded to treatment, and much better than people who did not get a liver transplant. Now, the thing is, though, like, they really were very selective on who they chose. And so instead of saying, hey, you know, we're just going to take an arbitrary number of 6 months, instead, they looked at people who, you know, they were assessed by an addiction specialist, they were assessed by an anesthesiologist, they were assessed by a liver specialist, a nurse. And they said, hey, you know, if you had very good psychosocial support, if this was kind of your first episode and you didn't realize, and, you know, we know that you're going to have a bad outcome and you are like sort of committed to not drinking anymore, you know, then, you know, we can do the liver transplant. So they really were very selective about choosing people that they thought would do well. And I think, you know, the reason we did this is because, again, alcohol is like any other disease, right? So there was actually a time, you know, when hepatitis C was very difficult to control, right? And so, you know, sometimes we would say, hey, you know, this person has this like uncontrolled disease and we think there's, you know, going to be recurrence and they're going to have a really bad outcome, so we won't do the transplant. And so that's the idea of, you know, transplant for alcoholic hepatitis. We really want someone who their disease is controlled, like the alcohol use disorder is controlled, and they're going to have a good outcome. So that's why, you know, it's not just the liver specialist, it's a whole team who decides about if this person has well-controlled disease and are they going to respond, do they have indications for transplant, are they going to do well after transplant? And again, like that kind of is a testament to how alcohol use disorder really does, it's a holistic disease. And that's why we also have psychiatrists and addiction specialists who work with us. And it's not just a liver doctor who assesses this. And, you know, using that very selective criteria, you know, there was a very low rate of relapse after transplant. You know, it can never be zero, right? We don't want to be so selective that, you know, you know, it's a balance, right? We don't want to refuse everybody. So unfortunately, there is a relapse rate, and that's usually around 10%, but we try to keep that as low as possible. And so in conclusion, I think, you know, Tasha showed you that alcohol-related harms are very prevalent in Canada, worldwide. They're on the rise. And so, you know, I think it's important for people to know that the 6-month rule no longer applies. We are doing liver transplants in patients who, like, carefully selected candidates, and we're getting really good outcomes. But the best treatment is really abstinence and trying to avoid, you know, a major operation with a 10 to 20% risk of death and having to be on lifelong medications afterwards. You know, really, you know, the best treatment is prevention, and trying to stop drinking before this happens would really be the best treatment. And it would be, you know, with your physician, also with like a therapist. And we really need, you know, unfortunately, there is a lot of stigma around alcohol related liver disease. There is a dearth of studies because, you know, we haven't had a lot of drugs to treat this. And there is a stigma, you know, that around this. And so I think it's important that we talk about this and we really focus our efforts on getting more data in this area and helping this patient population. And so with that, my talk is over, and I'll hand it back to our moderator.
Perfect. Thank you for that, Cynthia. Amazing. It's very interesting to get this whole perspective from alcohol-related liver disease concept to all the way to transplantation. And we'll take a few questions. I know we kind of have general questions that we've been getting from, at least from the foundation perspective, where we get inquiries from patients and caregivers who oftentimes, when they do get a diagnosis, that's whether it's early stage or late stage cirrhosis that was due to alcohol, they're, I guess, often wondering how, if they were to stop consuming alcohol entirely, how soon or what are the chances of their disease actually either not progressing or perhaps even their liver fully recovering. So that seems to be one of the main kind of questions I find that is constantly being asked, at least from our end. So perhaps both of you kind of just maybe quickly touch on that aspect, how much, depending on maybe if it's early stage, perhaps cirrhosis, or early stage alcohol-related liver disease, if somebody were to completely abstain from alcohol, is that promising for them to be able to reverse this condition or perhaps slow down the progression of this continuous damage?
Yeah, absolutely. I think we see a lot of patients actually who are able to recover some of their liver function. I would say it usually takes 6 to 12 months. So it can be up to 12 months to fully see the effect of abstinence. And as I showed in that slide, you know, there is unfortunately a point of no return, but who knows, right? Like you may have very, very good, you know, impact by stopping alcohol completely. So we always advise everyone, like it's never too late. You know, whatever liver function you have left, you know, will be improved by stopping alcohol completely. And as I showed, like if you have early to moderate stage cirrhosis, definitely can have an impact. Hard to say with late stage, but you should still, it's going to prevent the disease from progressing even further. So I think no matter where you are on that spectrum, abstaining from alcohol completely will definitely help you.
Tasha, anything to add on your end?
Yeah, I agree. I'd usually say the same, like the 6 to 12 month period. The other thing I just try to emphasize to the individuals that I see is that alcohol-associated liver disease is essentially our most reversible liver disease. So it really can have a huge impact, especially in the earlier stages. But often people are told by many of their healthcare providers at that point that they even have end-stage liver disease already. So it kind of depends on your perspective. But people who have, like we showed, those decompensations, ascites, like all those things can go away with stopping alcohol. So we really do encourage it to try and give that a chance.
No, great. Thank you for that. Actually, one question that did come up earlier in the talk with one of our other social networks was somebody who has an existing liver condition that is not related to alcohol. It is advised that that they don't consume alcohol. Most of the time, the doctors do recommend it. I guess what's the rationale or what's the reasoning behind telling somebody, a patient or a caregiver, if they have an existing liver disease that's not caused by alcohol, why it's not recommended perhaps for them to drink? I'll go Cynthia first, and then Tasha can comment after.
Yeah, so we know that alcohol is a toxin for the liver. And actually, we talk about those low risk alcohol guidelines, there's actually a lot of controversy over them. And I think the WHO came out like a few years ago saying like, alcohol is actually a known carcinogen and we shouldn't be drinking anything, but it's just, there's medicine and then there's reality, right? And like, there's so much, that kind of pressures us to drink, right? So alcohol is a toxin. And so when you take somebody who already has liver disease, right, from some other cause, and then you add in alcohol, it's like adding like wood to a fire, right? So we know, like in patients with like non-alcoholic fatty liver disease, if they are also drinking, actually people have they see like a synergistic effect, like even a worse outcome than if you just had alcohol or you just had fatty liver. We see that also with hepatitis C, patients who also drank heavily had much higher rates of scarring and damage to their liver. So the problem is you already have something that's causing damage to your liver. You're adding in a known toxin to your liver. And then the two of them just like together, like make even a worse outcome. So that's why, if you have significant liver disease, if you're already having some scarring and damage, we would advise abstaining from alcohol completely, just as you would take your medications for, if you had autoimmune liver disease, you're taking medications to protect your liver. So you should, not take toxins that damage your liver. I don't know what Tasha thinks.
Tasha, anything on your end?
Yeah, unfortunately, it's probably not what anyone wants to hear, but I was having a discussion with a group earlier today how, it's a low risk and not a no risk drinking guidelines, and it's meant for people who don't have any other health problems when we're talking about those recommendations. And so it's challenging. It's kind of like knowing like it is a toxin. It's kind of like having low risk smoking guidelines where a couple of cigarettes a day maybe won't hurt. If you have underlying asthma, maybe it's even a worse idea. So unfortunately, our society has normalized alcohol consumption so much that it's difficult for everyone. It's difficult for your healthcare providers. It's difficult for patients to understand like why we're trying to kind of paint this picture, but it is really potentially quite harmful. And our most common cause really of other liver diseases are non-alcoholic fatty liver disease. There's really not enough evidence at this time to say like what amount of alcohol would be healthy or safe to consume. And so I do generally suggest that people avoid, which is hard. We appreciate.
No, it's great. That's definitely one of the common questions I think come across Foundation as well is what is how much, right? People feel like they need a number or a specific answer as to if I consume this one, if I'm going 1 or 2 over the guidelines, does that put me 1 or 2% more at risk? Which in a way, it's a very valid question. I think it's important for people to kind of have an idea, but it's also like Cynthia was saying, realistic, right? To kind of look at it from that perspective. I guess I'll just have maybe 2 more questions here. One relating to the kind of treatment side of things. I know you both mentioned there are some of the therapies and some of the medications haven't really been shown to be as effective long-term. Are there anything perhaps that are currently being researched or that are showing promise for whether it's cirrhosis or inflammation, but also specifically to alcohol-related liver disease, or some hope in terms of future medications? guess I'll go Tasha first and then Cynthia next.
So I guess people are wondering more specific maybe for liver than alcohol use disorder. So yeah, with those, I'd say it's very early days yet. It's really not anything I could think of that people would want to know about at this time, unfortunately. Like a lot of like rat models, that kind of stage of research. So it's really still too early. Unfortunately, I think a lot of just even understanding the disease, like we're nowhere near at the point where we can get really good targeted therapies that will be available to people like in the next 5 years. I can't foresee that happening. They're still at a stage where even for like the alcoholic hepatitis Cynthia was talking about, they're still trying to figure out how to diagnose that properly, never mind treat it. So I think unfortunately we're quite a ways away from having any new good therapies, and really nothing is better than stopping alcohol consumption that we know of at this point in time, unfortunately. I don't know if Cynthia, you want to go deep into the basic science, but I don't think it's helpful.
Well, I think, it's very not glamorous, right? Like it isn't like the newest pill that we can give you. Like it's stuff like, maybe nutrition helps, like patients are like very malnourished. Usually when they drink, like alcohol is basically empty calories, right? So there was some data suggesting that if you had a good nutritional status, that might be helpful. But again, it just kind of highlights the lack of like industry pharmaceutical sponsorship. So we don't really have great treatments. It's like maybe if you eat healthy and have a good nutritional status, that might be helpful. But I don't really have anything more than that to say.
Yeah, no, that's fair. I guess there's probably better outcomes for those who can adopt a healthier lifestyle, whether it's a healthier diet or healthier routine. They may be able to perhaps cope with some of the complications of cirrhosis at least, or perhaps some kind of hope there. I guess for the final question, perhaps maybe from both of your views from your professional experience over the last, I guess, almost 2 years now during the pandemic, there's definitely been some coverage and there's been media headlines on increased alcohol consumption in Canada, also globally as well. Perhaps both of you can maybe touch base or comment on if you did indeed see an increased number of patients who were diagnosed with alcohol-related liver disease since the pandemic started, or before the pandemic and I guess during the pandemic, and perhaps what maybe resulted in some of those increases from a social behavioral perspective, and anything you may kind of give off as a final comment for those tuning in, being early December, going into the holidays, and of course, everything we've been through and still going through with the pandemic. I'll go Cynthia first, and I'll pass it to Tasha after. Loaded question, I know.
So I have to say, from a liver transplant perspective, we have our program for early transplant for alcohol-related liver disease. And I was speaking to our coordinator, and she's saying that we're getting like 30 referrals a month, like a lot. That's a lot, which I think is very scary. And I think what people may not realize is that the face of alcohol use disorder is like changing in Canada. Like it's a lot younger, it's a lot more women. And I think that, people are hiding it a little bit, like there's that stigma, right? And I think it's important to recognize that everybody is susceptible. It's not necessarily the people that you think are, addicted to alcohol are those people, right? Like it can also be people who look very high functioning, very young people, women, and these are the type of people who might hide it a bit more, right? So I think it's important to recognize that this pandemic has been very difficult. It's isolated us all. What's an easy way to forget your troubles? Go get a drink, we use it to celebrate. We use it to commiserate, so definitely we've seen more and more severe disease, and I think it may not be the people that you think necessarily who are affected. And I think it's important to just be open about it and to recognize that it's important to get the help, because again, you could really prevent really bad disease moving forward. And it's, you know, it's important to recognize there's a problem, stop it early so you can prevent. You know, it's really scary how many young people we have under the age of 40. So if you say like, oh, it's not going to happen to me because I'm only 20 or 30, or, you know, like it's happening to people. So I would say really, you know, just take a look at your alcohol consumption. And I don't want to be a killjoy, right? So that's why the audit, right? You know, like that one screen, it's 4 to 5 drinks, right, is a problem. So if you have no liver disease, right, I don't want to be that killjoy in the holidays saying like you can't, you know, celebrate. But, you know, there's other ways of, you know, celebrating with your family and friends. And maybe we need to look at that, right? After a pandemic where we've all been isolated, maybe the treat is getting together with our family, right? So not necessarily has to be the alcohol. So.
Yeah, no, great point. Tasha?
Yeah, I guess getting together with people also a risky thing these days. So I don't know what's worse. But yeah, I think we do know, like people can search online too. There have been studies to show that alcohol consumption has increased in Canada and many other countries with the COVID-19 pandemic. I think there's a few kind of more locally in the Maritimes that they've looked at in terms of data of increased use. And in Canada, I think like 25% or so of people would have had increased alcohol use. So we haven't actually studied that at our center, but anecdotally, I'd say, in just talking to people, it has been a change for a lot of individuals where they're perhaps at home a bit more, so not having to drive. And so that sometimes is a reason I found in talking to people that they've been consuming more alcohol. So it does seem to be, I'd say, increased just anecdotally, and then in studies that have been done out there. And I believe people can keep an eye out. There will be a study published out of at least Ontario data looking at like the hospitalizations and liver-related complications related to COVID-19 compared to before, coming out pretty soon. So that'll be, I think, more firm information to know. But it's definitely a phenomenon that we've seen, I think, and unfortunately, same recommendations as any time, where probably moderation, like anything, is a good idea.
Agreed. Perfect. Thank you for that. And with that final answer, we'll conclude our webinar for today and for this evening. And again, a big thank you to our two experts here. We got Dr. Cynthia Chen and Dr. Tasha Kalai for the great presentations and extremely informative, from a general audience member to even somebody who's a bit more versed in this condition and liver disease as a whole. So definitely extending my great thanks to both of you. And of course, our thank you to our partners at the Canadian Association for the Study of the Liver for helping us out with this webinar. As mentioned, this webinar will be available on the CLF Facebook page following this live stream. It will also be available on our website and our YouTube page over the next few days. And to learn more about alcohol-related liver disease or any liver disease, or to find out about the Canadian Liver Foundation, please visit us at liver.ca, and to follow us on social media, our Facebook, Twitter, Instagram pages for all the most up-to-date information and liver health tips. And with that, I do want to thank you all for attending, and hope you have a great rest of your day and evening.